It's an honor and a pleasure to be over here, and I state over here that I have no disclosures, but there are some disclosures. I'm not a pediatrician, and the talk I'm giving is not an area of my expertise, but bear with me as I lead you. This is an area where our School of Public Health hopes to invest a lot. And I think the title of the talk itself emphasizes why we strongly believe that in order to talk about public health, we need to be talking about child health. And it in fact reflects a contract that all of us in this room have for the next generation. These are some of the key references. I read hundreds of articles in preparation for this talk there's always a trepidation when you stand before pediatricians to talk about child health. But these are some of the key references from the National Academy of Medicine, which might be useful. And I'm happy to leave a copy of these slides in case people are interested. I picked this title partly provoked by an article in The Atlantic just about 3 weeks ago by Derek Thompson. He's a reporter in The Atlantic who's been writing a lot on the theme of public health. Last year he wrote about America being the rich death trap. And surprisingly, about 3 weeks ago, he turned to what he called as the civilization test and asked the question, the true test of civilization may be the answer to the question, can it keep its children alive? And he came to the sobering conclusion that America fails the civilization test. I hope to unpack this question for you and to modify it a little bit. I think it's important to keep our children alive, but that's not enough. We need to keep them alive and healthy and well. And why might that be important? Sounds like a very flippant question that we should even discuss this. But it turns out there are many reasons why we would want our children alive and healthy. And we could pick from different branches of disciplines. If you pick from evolutionary biology, for example, among the most conserved traits across invertebrates and vertebrates is the diverse trait of looking after one's young ones. It's almost critical for the existence and the continuation of the species from an evolutionary perspective. It's also very important from an economic perspective. Societies that do not have enough young children or enough young population tend to struggle economically in terms of the workforce. There's a more fundamental reason we should be talking about child health, and that has to do with issues of basic justice, social justice. A child does not choose to be born. A child does not choose his or her parents. A child does not choose the family he or she is born in, the neighborhood he or she is born in, the state he or she is born in, the country he or she is born in. In fact, what it means is that the child lacks agency. So when somebody lacks agency, the immediate response is the response of social justice as a species requires that we address this question. And that's what I'm going to do for you. And there are 6 parts of my talk. And I'll begin with some key messages and concepts. So in case I lose you in the middle of the talk, or you choose to leave or doze off, I'll repeat them at the end, so you won't have missed anything in between. I want to talk about, when you talk about children in the country, who are we talking about? What does the child population look like? And then talk a little bit about how are these children doing in terms of unquestionable and important health metrics. Segue into why do these metrics look in a way that Derek Thompson had a verdict that we are failing the civilization test. And then talk about the important thing, can we do something about it? And then sum up. So those are the 6 parts of my talk. And some of the key messages, and I'm going to spend a little bit of time on this before we get into the meat of my talk. Child health and children are embedded within biological hierarchies. We heard this talk about E. coli sepsis. We heard this talk about resuscitating extremely low birth weight. We are talking about biological hierarchies, individuals. How do we get the child to leave the hospital alive? But this child who leaves the hospital alive rests or nests within sociological hierarchies. And I'll unpack that term for you. So the child is embedded in these hierarchies, and the child embodies lived experiences. What you see in the ER or what you see in the NICU might reflect something that is a bodily manifestation of something that is happening outside the hospital, and that's called embodiment. Child health disparities, and there are major challenges in our country, are driven by health inequities. These inequities may be related to race, they may be related to geography, they may be related to a bunch of factors. So you need to look at these inequities disaggregated. And I'll disaggregate it for you to see how the children in the country are doing by both race as well as by geography. These inequities begin actually before the child is even born. Talk of agency. Even before you are born, there is a cadence of activities or inequities that are baked into the fabric of society, and they unfold as the child health unfolds. After birth, infancy, early childhood, referred to as critical periods. And child disparities, we mean differences in health outcomes among groups of children. Inequity is a different term from disparities. It refers to differences in outcomes that are unjust, that result because of certain practices or certain policies, often which reflect resource-poor social environments and policies. And the classic tussle between, do we want financial capital or do we value social capital? This is the classic battle, and I'll unpack these terms for you. Child health trajectories are shaped by exposures. Preconceptional, in utero, infancy, early childhood, and they are probabilistic. I want to emphasize this term because it means they are not deterministic. It means they are mutable. They can be changed if we do something about it. And what can we change? If we change resources and the stability of relationships. So we're talking about the next bullet, which is early living conditions that a child is exposed to, is a key determinant of mental, emotional, and behavioral well-being. And early childhood care and education, sometimes referred to as ECE, promotes whole health for the child, and I'll define what we mean by whole health. So what this means is, if you add up all the bullets, it means if we really want child health inequity to go away and restore child health equity, it requires an approach that has to be over the life course and that has to be integrative and equitable. It means necessarily aligning sectors outside the healthcare field. Health is not healthcare. And that means we need to deal with aligning child and family serving sectors. There are many evidence-based approaches that work. I'll show you comparisons with other countries, which basically tells us that there's nothing new or nothing, it's not rocket science. Others have done it. So what this leads to is, what does it take for us to do it? And I'll leave you with that question. So I want to start with talking about the rights of children. In 1989, in New York, there was a UN convention on the rights of children, and there are about 42 of them. A few of them are pictured on this slide. But the UN Charter is very clear. These children have a right to a childhood, a right to be healthy, a right to be educated, and a right to be treated fairly. And there is no hierarchy of these needs. And these needs and rights are universal. So when there are rights and needs, they go with responsibility. And given the lack of agency in children, These needs and these rights mean the adults have the responsibility to deal with this. Coming back to this concept of whole health, it just doesn't mean physical health. It just doesn't mean environmental health. It just doesn't mean that the child leaves the hospital. It means that the child actually thrives, has emotional and social well-being, has secure home and neighborhoods. And the whole health concept leads to what's called as the whole health care concept. And the whole health care concept is premised on 5 key principles, which are at the bottom of this slide. It has to be not just disease-focused. It has to be not just patient-centered. It has to be people-centered. It has to be child and family-centered. It has to be holistic. That's the pie chart. It has to be upstream-focused, and I'll unpack that term for you. It has to be equitable, no child left behind, and often requires a team-based approach involving the healthcare, but also involving players outside the healthcare industry. So a little bit about the life course development concepts. There are many models of life course health development, and I'm distilling 5 key principles. And the first one is called the unfolding principle, is that the child health, it unfolds over the lifespan and during childhood. And it's an emergent property. Emergent properties reflect properties of what we call as complex adaptive systems. They respond when they face stressors to manifest newer properties. They are emergent properties. And this child health unfolds over the lifespan. So that's the unfolding principle. Then there is the complexity principle. Child health is dynamic, nonlinear, multidimensional, multidirectional, multi-level, and mutable. A lot of M's here. And I can explain that to you. If you look at the child and look at the aging of the lungs, for example, the peak lung function is in the 3rd decade of life. If you look at blood pressure, it peaks in the 2nd decade of life. So different organ systems, they mature at different rates. And I'll unpack the development of the brain specifically during this talk. So that refers to the complexity within the same being, a child. Then there is the time principle. Because different organ systems, they mature at different rates, the impact of exposures that the child experiences on different organ systems may depend on what organ is developing at a particular time when that exposure happens. And this is called the timing principle. Related to the timing principle is the plasticity principle. When an organ system faces an exposure, there are peak periods during development when it actually is resilient and it can move in different directions. It's not set in stone. There are other times when the plasticity is lost and you lose the ability to regenerate or to respond in particular ways. And the last principle is called the harmony principle, that this cadence of child health is the result of molecular events that unfolds in nanoseconds, biochemical events in milliseconds, behavioral events or processes that unfold in years to decades, cultural processes that take centuries and are handed from generation, and evolutionary processes, I began with that take millennia. So you're seeing this cadence, this beautiful child that you see, and the health that unfolds is the cadence of a complexity that is ranging from nanoseconds to millennia, and that combination. There's a lot of talk in pediatrics about the first 2,000 days. If you do the math, that's about 5.5 years. And the reason it is emphasized is several organ systems, we have reached our capacity by the first 2,000 days. And actually, this distinguishes us from some of our ancestors. If you look at some of our ancestors, the apes, they have molars by the time they are 3 years old. We don't develop our molars by the time we are 3 years old. Why is this development delayed? It's because what distinguishes us is that the brain is highly sophisticated in its development, and it sucks up a lot of energy, and it takes time to develop the brain. So when you're born, about 25% of your brain size is developed. By the time you're 2 years old, it's about 75%. By the time you're 5 years old, it's about 90%. That doesn't mean that the child is an adult. It depends on what functions we are talking about. So if you take the first 12 months, we're talking about development of language, vision, hearing, and higher level cognitive function. And if you extend this across from years 1 to 5, you begin to understand social skills, emotional control, and habitual ways of responding. So from this thing that happens at the level of the child, this complexity, I want to zoom out and talk about the sociological hierarchies in which the child is embedded. And this is a figure from a landmark paper in the Lancet, a review article on child health development, where you can see that the blue circle and the blue arrow is the child at an individual level, but the child nests within a family, that nests within a neighborhood, that nests within a healthcare system or a political system. And the famous developmental psychologist, Bronfenbrenner, he was at Columbia, he came up with this notion of cross-permeable systems, that the individual nesting within biological hierarchies are the microsystems, and they interact with the family and the sociological factors, calling the mesosystem, that interacts with the exosystem, which is the built environment, and that interacts with the macro system. You can see it's a complex five-way interaction that's going on over here. That is a determinant of what you see when the patient or the child presents to you in a well-child visit or a sick child in the ER. So it reflects this combination of interactions. Things go wrong in life. That's the norm of life. And sometimes we call it adversity. And how does that impact children? It depends on when does it happen? How long does it take? How many of these adversities did the child face? What kind of adversity it is? And how does it relate to the organ system development I spoke about, which is time-specific, and the life stage-specific? And all this plays out by activation of things that are not visible to you as a pediatrician because they are latent, or activation of biological pathways, or cumulative effects that are telescoped in time to one day present in your clinic with symptoms of a disease condition. I refer to the notion of embodied experiences. And what you see on this slide is what I refer to as biomarkers of structuration, or the structural determinants. That whenever you face adverse circumstances, sometimes referred to as othering, the body undergoes what we call as weathering, or allostatic load. And that's because of activation of the sympathetic nervous system, the hypothalamic pituitary axis, and then you see at the bottom of the slide, to link it up to the E. coli sepsis, the NRLP3, that's the nod-like receptor protein, and that's the inflammasome that triggers interleukin-1 beta activity, interleukin-18 activity, and you see that on the right side of the slide, the pro-inflammatory cytokines. So what we are experiencing from the exosystem and the mesosystem, we embody in the form of molecular triggers and activation of pathways. Another term I referred to was embedded experiences, because we are embedded in circumstances. And what you see on this slide is in the green a positive trajectory, and in the blue is a negative health trajectory. And both children are embedded in a social circumstance. So again, there is a five-way interaction going on here between the genome, the epigenome, the envirome, the lifestyle stage, and the particular timing of a particular environmental stressor. And I refer to cradle to grave. Unfortunately, the story is deeper, because not only do you transmit it, or you don't take it to your grave with you, you actually transmit it to the next generation and to the next generation. These are epigenetic changes that are well documented as a response to adverse environments that are passed on from generation to generation. And it's not just the epigenome that is transmitted. We also transmit behavior. We also transmit culture through the mesosystem and the exosystem. So with those basic concepts, let's dive into, when we talk about the children in the country, Who are we talking about? So when you look at the 2020 census, we have approximately about 73 million children in the country. Between 2010 and 2020, actually the child population decreased by 1 million for the first time since the Great Depression. If you look at the growth in the child population between the census 1990 and 2000, there was approximately about a 13% increase. Between the 2000 census and 2010 census, there was a much smaller, about 3% increase. And between the last two census, 2010 and 2020, there's actually a decline in the child population. That being said, among these 73 million children, 53% of them are children of color. So the US is already a majority minority, within quotes, child population. Out of these 73 million, close to about 18 million or 25% are actually Hispanic Latino children. And to break it up for you, the growth in children between the two censuses, although there was an overall decline by about 1 million, the proportion went above 50%, the children of color. A lot of that is fueled by not only Hispanics, but also people who identify as biracial or other race, and the Asian as well as the Native Hawaiian children. So the child population in this country is becoming very diverse. Why is this important? Because when we are talking about child health in our democracy, and that's the future, we are talking about a multi-racial, multicultural, multi-faith democracy at scale. So when you think about this and its implications for the future of public health, you can begin to see why diversity might matter. And that is the reason when I go to the second part of my talk, I'm going to unpack these metrics, disaggregate them by both diversity as well as by state. So this Sunday is Mother's Day, so I thought you can't really talk about child health without talking about maternal health. And when it comes to maternal mortality in the US, we are about 4 or 5 times that of our developed country peers. Just think about it. 4 to 5 times more mothers die in this country as a result of pregnancy. In fact, this is not new. I'm talking about this in 2023, and what you see in the inside embedded there is actually an op-ed by Christopher Ingraham in the Washington Post in 2015, where he spoke about the maternal mortality rate being a national embarrassment. And what you can see on this slide is the green line is the way maternal mortality is tracking, and these are data till 2017. I'll show you how it goes after 2017. Look at the blue line, which is the average developed country in the world. Others have done it. We are not doing it, and that's the gap. What happened after 2017? You can see the slope of this curve is moving up. Not okay, not acceptable. And this is not because either our mothers are young or our mothers are older. At what you see on this slide, regardless of the age of the mother, across time, maternal mortality is increasing in our country. Not only is it increasing, the burden is unequal when you disaggregate it by race. Black women in our country are 3 to 4 times more likely to die from pregnancy-related causes than white women. Native American women are about twice as likely to die as a result of pregnancy compared to white women. Why might that be the case? Perhaps it has got something to do with the fact that about a third of our counties, we have about 3,000 plus counties in our country, about 1,000 of them are without a hospital or birth center that offers obstetric care or has obstetric providers. And you can almost see this band across the middle of the country, which tells you that where the mother lives might make a difference in whether or not she dies. And the color of her skin might make a difference of whether or not she lives. I said black pregnant women have a higher mortality, and I said geography, it varies. there is homogeneity in this observation that black mothers, no matter where they live in our country, they do worse. Whether they live in areas with low pregnancy-related mortality rates or high, it's about a threefold difference, which I said was not acceptable. Let's move from maternal mortality to the topic children, and let's talk about infant mortality rate. How do we do? It turns out that infants die at twice the rate in the US compared to our developed country peers. And there are two different definitions. No matter how you look at this, it's twice the infant mortality rate in the US. If you divide it in infant mortality rate into neonatal and postneonatal, as pediatricians, you control a lot of the neonatal mortality with your NICUs and the advances. It turns out that the neonatal mortality is about 50% more than our developed country peers. The neonatal mortality is about double. So this is happening outside the hospital, where it's going to be hard to save these children unless we do something, and we'll unpack what is it we can do outside the hospital. Infant mortality rate, the good news is that globally it is falling. That's one of the achievements of our civilization. But it turns out the US, it's not dropping as fast as it should or as it could, so that the gap is increasing, as you see over here. I said I would disaggregate it by race, and here you find out that the infant mortality rate of children, infants of color, it's substantially higher than whites in the country. Again, telling us it's possible. It's possible in this country to have low infant mortality rate. It just might vary based on the color of your skin. It might just vary based on where you live. And you see over here from 4 to 8 per 1,000 births infant mortality rate, and you can see that there's a cluster in the south that does not seem to do well. How about under 18 mortality, child mortality? It turns out that if you rank all the top 20 developed countries about child mortality, the US is 20th out of the 20. It ranks right at the bottom. And it's been that way. It's been that way for 50 plus years, which begs the question, what are we doing about it? In fact, this article, which just came out this year, a couple of months ago, points out that child mortality might actually be increasing over the last 3 years. 10% between 2019 and 2020, and an extra 8% between 2020 and 2021. And it's one of the causes of death is homicide. Talk of homicide of children. This is related to firearm-related injury. That's what the data say. Again, child mortality may vary based on where you live. Again, you can see a cluster in the south where child mortality rate is substantially higher than that in the rest of the country. It also varies based on the color of your skin. And what you see over here is that black children, you can see, have about 6 times the risk of dying due to firearm-related injury. And furthermore, this difference is escalating. And you can see for the last 4 years, if you plot them over there and you look at it, it's something that's increasing steadily. Again, these data for us are a wake-up call. Why is it increasing, and what is it we can do about it? That's the question for you all to look into. Perhaps some clues as to why infant mortality, maternal mortality, child mortality are so badly off might have to do with what we call as social determinants of health. And let's start with poverty, the mother of all maladies. And what you see here is the child poverty rate for the developed countries. It's around 12%. That in the US is about 20%. Turns out children are more likely to be poor than adults in our country. Talk of agency. How do you justify that? It turns out among the children under 18, the segment that has the highest rate of poverty are the infants and toddlers. Talk of agency in that group. And poverty rate is influenced by the color of your skin. What you can see over here is that the black children and infants and toddlers and Hispanics, they fare about 2 to 3 times as badly as compared to the white peers. The good news is that some of this is changing. It's tracking in the right direction. Child poverty rate in the country is coming down. It still clusters geographically. So your color of your skin, where you live, might be impacting your child poverty rate, and that might have something to do with child mortality rate. It's decreasing, but there are still some parts where it is increasing, which bears watching. And about 50% of the counties where child poverty increased, they happen to be in the south. Think about it. And the disparities that persist, child poverty, like I said, the highest proportion is in the infants and toddlers. And that's an area for active research and mitigation. Another interesting factoid for you to reflect upon is what is shown here by the top curve. It shows the proportion of children by race who are living in poverty. And since 1974, between 30 and 40% of black children have been living in poverty. Think about it. What does it tell us about equity, about our values? And this slide has an interesting insight where you look at kids born in 1955 to 70 and children born between 1985 to 2000, and you look at high or medium poverty. You can see the red bar going further, meaning that as the country has progressed economically and done well, the lot of the kids has gone southward, so to speak. Poverty, another one is hunger. How hungry is our country as compared to its peers? It turns out it's about 50% higher prevalence of food insecurity in our country compared to its developed peers. About 15% of households with children are not able to have adequate food on the table. And about 1% of them are markedly food insecure. And much more in children of color. Again, there's a theme over here. Any of these data you disaggregate it by race, you can see by the color of the bars that the black and Hispanic children, they fare worse when it comes to food insecurity. I said I would disaggregate by geography. You disaggregate it again, it clusters. Food insecurity is relatively high in the southern states. Might that be the reason, the child poverty and the food insecurity that might be associated with the high infant mortality rate and child mortality rate? Could it have something to do with adverse child events? Adverse child events can be broadly categorized into 3 bins. Those that is done to them, they are treated badly, either physically, emotionally, or sexually. Those where you don't do something which is required, a hug, a smile, physical contact, or those where the child witnesses something else that is going on in the family. Intimate partner violence, divorce, substance use, mental illness, or a parent in jail. And what that translates into is behaviors and health outcomes. Behaviors such as smoking, substance use, alcohol use, and disorders such as obesity, depression, suicide, diabetes, heart disease, with a clear dose response. So how common are adverse child experiences in our country? It turns out that 1 in 3 children have had at least one adverse childhood experience as defined in the previous child. 1 in 7 children, about 14%, have had 2 or more adverse childhood experiences. So if we break this down by race, I said 1 in 3 children have at least one. It turns out 1 in 2 Hispanic children and 2 out of 3 black children have had at least one adverse childhood experience. And at least a third of the black children and about a fifth of the Hispanic children have had at least 2 adverse childhood experiences. And where do they cluster? The burden of these adverse childhood experience also is geospatially heterogeneous, with some clustering in the south, but also in other parts, including Vermont in the northeast and Wyoming and New Mexico. So you see, this is a different pattern from some of the others. Another fact to think about as we think about social determinants of health is we spoke about the desegregation of schools. And what this slide captures is a trend which has been going on for the last 30 years, which is the reverse of what we call as resegregation of schools. And that has health impacts on children. And you can see pretty consistently, no matter which part of the country you live, there is a resegregation phenomenon in practice. And what this means is that black children are more likely to attend poorer schools, twice as likely as white children. The linkage I'm making over here is that we all know from schools, schools depend on the quality of the school, or education depends on where you live. And where you live might depend on race. So there's an ecological correlation between black children and the odds that they might go to a poorer school. And this manifests, and these are data from a study called the Panel Study of Income Dynamics, PSID. This is a study of about 3,000 white and black children who were followed up multiple times every 5 years, from 1997, 2002, 2007, 2014. And they surveyed them in relationship to whether or not they attended a segregated school. And the verdict in this paper was very clear, that segregation or resegregation is associated with adverse health outcomes in black children. So these are additional metrics, and I'll try to go over this part quickly because there's a theme over here. If you look at education, if you look at family and community, and the colored boxes reflect the non-white race, you'll find that most of those metrics are worse off compared to what you see on the right side of the slide, the whites. The biracial children, they fall somewhere in between. And again, that's suggesting a pattern and a trend as the proportion with biracial kids in the country increases. If you look at low birth weight babies, if you look at teen obesity, again you see a similar pattern playing out. People of color do worse. Why does it matter? And how early does it matter? So this is just a smattering of data from a landmark study called the Adolescent Brain Cognitive Development Study, the ABCD study. And basically, to summarize this study, what it showed is that kids who have adverse childhood events, the cognitive development, the brain size, the brain development, they are worse, whether it's defined by lack of sleep or whether by excess weight. And when you adjust for those social determinants, some of these racial differences disappear, suggesting that these are determined by what I defined as the mesosystem and the exosystem, rather than the child itself. So what can we do possibly about these things? There are some very good things that work in the developed countries, in the OECD countries, because that is the norm. Paid parental leave for moms and dads, breastfeeding breaks at work, paid leave to take care of sick children, income support via minimum wage, tuition-free primary education, affordable housing. This is standard of care in a lot of the developed world. I mentioned the fact that health begins outside the hospitals, and that begins in healthy communities. So some of the things that could be done and that have worked elsewhere: redevelopment of neighborhoods, desegregation of neighborhoods, policy reforms regarding incarceration of the parents, regarding jailing for minor drug use, firearm safety. And the pediatricians come in too, training physicians, pediatricians for social needs screening when you have your encounters, medical encounters. So here are some landmark studies. I just cherry-picked some of these to show that these are long-standing community-based interventions. So I pulled these out particularly because it struck me that these are long-standing projects. So the ABC Darien project began in Orange County in North Carolina between 1972 and 1974. Very small size, 111 children, divided into two groups. One had the ABC Darien. ABC Darien is a word that actually means rudimentary, meaning the elements of learning the ABC, so to speak. And they did an intervention and a control. The intervention arm, they actually read to the children. They actually spoke to the children. They played games with the children. And they actually hugged the children. And when you do these things and compare them with controls in this particular study, and you follow them out, At age 4, you can see the cognitive development in red is the treatment group. That's the abecedarian model. And the other one is the control model. These were all predominantly African-American children. I forgot to mention that. These 111 children were African-American children. And this is a dichotomized variable, IQ greater than 84. But if you look at the standard deviation of increment, usually for psychological tests, if something has an effect more than 0.25 standard deviation, it means you can change policy. The effect size in this particular study was 1 standard deviation. It was 4 times as much. So begs the question, when will policy listen? And by age 21, you can see that the odds that they would have college education, have skilled labor, were almost double. And that's the yield of the abecedarian project. It was criticized a lot because of the small sample size. But then we had the federal Head Start program. This began in the 1990s. Again, Head Start is you read to the children, you talk to the children. And what you can see in both these insets over here is whether you look at high school graduation rate or the odds that you have higher education, especially for the children of color, marked improvement in the Head Start program, suggesting that this is a program that works. Another landmark study was called the Moving to Opportunity. This was a study of about 4,600 families in 5 cities: Boston, Baltimore, Chicago, LA, and New York. And what they did basically, there was a feeling that children who work in environments or live in environments of opportunity, they do better. So they basically gave them housing vouchers. And the treatment arm had 2 groups. They gave a housing voucher and said, you have to move to an area where the poverty rate is less than 10%. There was another arm, they said, this gave a housing voucher and said, use it for better housing. And there was a control arm where they got no vouchers. And it turns out that if the child received, the family in a child received a housing voucher before the age of 13, then it had a major impact on adult earnings, attending college, and a lower likelihood of being a single parent. There were health-related benefits. Hemoglobin A1C level, diabetes rates were cut by half if you gave them a voucher to move to an environment with opportunity, suggesting these are long-term studies, community-based studies, and long-term follow-up, hard outcomes, both medical as well as non-medical outcomes, and it works. Another program that's attracting attention is what is called as the MIECHV program. It's a federal program where you visit the home. There's a team that visits the home in order to support the parents, encourage them to read, follow up regarding vaccination, identify maternal depression, and there's a evaluation program which is called Home V. It's evaluation of efficacy of home visits. So this is an interesting concept that we'll hear more about, where you take the care to the homes of the children and look at the health benefits that might happen. There are other major federal financial programs that directly reduce child poverty and by extrapolation improve child health. Earned income tax credit, child tax credit, supplemental nutritional assistance program that lapsed, women, infant, and children program, temporary assistance for needy families, all these, and you can see the impact, is it lifts children out of poverty. And when you lift children out of poverty, there's a direct correlation with improving the long-term health. And here's another one, the Medicaid expansion states versus the non-Medicaid expansion states. And you can see on the left side, the proportion of children that are below poverty and the proportion that are uninsured are much lower in the states with Medicaid expansion. Again, offering us thought, food for thought. What does it mean to have Medicaid expansion? Prevention of adverse childhood experience through resources and also through relationships, supportive relationships. Major impact on multiple outcomes. Depression, smoking, COPD, kidney disease. These are much more powerful than what you do in the hospital. And they reduce healthy risk behaviors. They promote also education and the likelihood of graduation and a range of health benefits just by having supportive home environments. So I want to end my talk by talking about windows of opportunity. That's what this slide shows, a window and opportunity. There are multiple times in a child's life where one can intervene. Before the child is born, in the healthy pregnancy-related and preconceptional premarital counseling, during pregnancy, during labor and birth, during the neonatal period, during the post-neonatal period, during early childhood. I focused a lot of my talk on early childhood interventions in terms of examples because they are some of the most powerful ones that in terms of the return on investments seem to deliver a lot. And this slide sort of encapsulates the different trajectories and how poverty, stress might lower the health trajectory, and how if you have supportive parental education, emotional support for the parents, reading to the child, health services, quality preschool, all these translate into major health gains for the child. Something that has to be delivered in a child and family-centered way, in a culturally and linguistically appropriate way, services rendered both in the hospital and with outreach at home. So I want to end with the key messages. Instead of the 9 bullets in 3 slides, I've reduced it all to 1 slide. Child health disparities are driven by health inequities. And we saw them by race and we saw them by geography. And they span the life course from before conception through early childhood, which are critical periods. Providing resources, stabilizing relationships with early living conditions, early care and education are among the most cost-effective ways to keep our children healthy and to meet our civilization challenge. Lots of evidence-based approaches I tried to show. All these work, and they are working right now in our developed country peers. Do we have the will to do it? And that's the question before you. And I want to end by quoting Nelson Mandela, who defined keeping our children healthy as a moral obligation. It is a moral obligation, and it has to be, in my opinion, a national obsession. Thank you for listening.